Welcome to Consulting Chai and welcome to yet another episode on hospital basics. Today we'll be covering about hospital operations and this will be in three parts. So now let's get started. So first I'll brief a little bit about the hospital operations part and then we'll talk about different topics. We'll talk about admission and discharge, we'll talk about bed management, we'll talk about how a centralized HIS EMR should be there. We'll talk about 24-hour emergency services, we'll talk about biomedical engineer, maintenance schedules, and we'll talk about pharmacy, inventory and dispensing. Okay, so throughout these three-part series, we'll be talking about streamlined patient admission and discharge process, where starting from where the patient comes and how the whole admission process is done, and then how the discharge process is initiated and how it is executed. That will be discussed. Then we'll discuss about efficient bed management and occupancy optimization. So how do we manage beds and how you should have a dashboard of bed management. We'll talk about that. Then we'll talk about centralized hospital information system. So if you have a HIS for operations purpose, what informations are required? So those things we'll discuss about that. We'll discuss about how the operations play its role in the triaging and response protocol in the emergency department. Then we'll talk about what needs to be seen from the operations point of view in biomedical engineering department. Then we'll talk about pharmacy inventory and drug dispensing scheduling. So again, the operations part of pharmacy. Then we'll talk about CSSD department, its operations. We'll talk about biomedical waste management, the disposal segregation, what are the processes there. We'll talk about housekeeping infection control routines, so the kind of work that goes on and on in terms of infection control and housekeeping. Then we'll talk about lab turnaround and the management of the lab. Then we'll talk about radiology reporting, imaging, archiving works. Then we'll talk about the OT scheduling, utilization, different indicators which are seen in operation theatre. Then we'll talk about manpower rostering and shift management, how different rostering it's done and how coverage of the 24 hours is done. Then regular fire safety and mock drills. So in terms of fire safety and mock drills, what needs to be done. Then we'll talk about vendor coordination for supplies and services. So stores operations part, we'll talk about that. Then patient flow analysis in OP, IP to discharge, how OP to IP conversions are done, how those things are monitored. Those things will be discussed there. Then quality indicator monitoring and KPI dashboards. So overall quality KPIs and quality indicators related to operations. Those things we'll discuss. Then we'll discuss about your internal audit cycle, your corrective action. Then we'll discuss about staff training, which is very important. Training of staff. How do we manage the whole training department? We'll talk about that. And then finally we'll talk about revenue cycle management, the billing to collection. Okay. Now about admission and discharge. So Very simply put, so admission can happen from OPD or emergency. So then we do counseling of the patient. So if the patient feels that the hospital is too costly and the patient will not be able to afford that, then they go for LAMA. Or if they are comfortable with the prices and all, then the bed is allocated. Very simple. Okay, so it can happen from OPD or emergency. Some might say that person can go directly to IP, but generally, even if you are going through directly to the IP, you should at least go through the emergency. So many hospitals have that SOP. Then see, the admission is consulted by doctor. So when the primary consultant says that you go for admission, they recommend that, then only the patient comes for counseling with the operation department. So consultation with billing department or operations. So depending upon the size of the hospital can either have a operations department with whom the patient counsels, or simply the billing department, they counsel the patients and then the patient decides. So once it is decided, bed is allocated, and once bed is allocated, they prepare the bed and then the patient is transferred to IPD. Now the discharge process. So this is on your left side of the screen, you can see the whole discharge process. So discharge process starts with call for discharge by the primary consultant. There can be other consultants as well. Say for example, a person who is going through a GI surgery or GI medicine. The GI consultant is a primary consultant, and the person also has diabetes, so endocrinologist will be the secondary consultant. So when both consultants, they give clearance from each independently, then only the call for discharge is taken. Then once the call for discharge is given, then intimation to all departments is given from the nurse station. The nurse station gives so the main departments here are lab, radiology, OT if it's a surgery case, pharmacy. There can be few more departments according to the patient's need, condition, the treatment line. So bills from pharmacy, they come. So the medicines are sent. So whatever remaining medicines are there, they are sent back to pharmacy. They minus that, they recalculate it, and then it is given to the billing department. And bills from radiology, how many lab investigations were there, how many radiology investigations were there. In case of OT, the charges of the surgery, if there were implants, anything, those charges, OT charging rates, all the rates are calculated, and it's given to the billing department. The quantity it's given. Then simultaneously, discharge summary is prepared by a medical officer. So a medical officer in consultation with the primary consultant, they prepare the discharge summary. Okay, it is one of the very important document, and the format is very clearly given in NABH guideline whether it is the entry level or it is the full level. Very detailed points for discharge summary is given there. Okay, so they prepare the discharge summary, and once the bill is cleared, a bill is prepared, and once the bill is cleared, then they get discharged. Okay, with the discharge summary, they take signature in the discharge summary from the patient or the attendant, and then the patient is discharged. This is for a simple discharge, cash discharge. Insurance discharge is much longer than this. Okay. Bed management, how do you do that? So on the left side of the screen, you can see these are different colors you can have in your HIS. So these are typical types of status of beds. So you can have blue for assigned bed, which are active patients where patient is occupying the bed, blue color. Green is ready, clean, its bed is clean, linen is changed, so a new patient can move in, that is green. Yellow is cleaning in process, so patient has just been discharged and the housekeeping, they are actively cleaning the room. Red is blocked, so it is reserved for specific case. So it can be either for surgery, it's for isolation, it's for VIP. Okay, so accordingly you can have different color for these. Then you can have an orange for dirty, so immediate post discharge. So after discharge, bed is there, so they are cleaning. The difference between yellow and orange is yellow is just before a patient moves in, the bed is being cleaned, and orange is just after discharge. Now they are cleaning the bed room or the bed. Gray, out of service, so maintenance, repair or deep cleaning is required. And lastly, you can have a brown color for patient awaiting final paperwork or transport. These are important. This is important so that you understand that this bed will be ready for another patient in few hours time. Okay, so operationally, first, to manage the beds, you should have a morning assessment where you review the overnight admissions, discharge, and you forecast. So forecast the day's bed needs. Okay, one very important thing, you should have a occupancy for profitability. To make break even, generally it takes around 55 to 65% for break even. Then 65 to 75 you are making some profit. Okay, good profit. And the sweet spot is 85%, 75 to 85%. It's a sweet spot, so where you have most of the you get the profit of running the hospital when you have 75 to 85. Anything more than that, it will be, the hospital will be too crowded, and you'll be facing a lot of difficulty in managing the beds. Okay, so the percentages I have spoken about, it's a general percentage. So when you do cost cutting, you can have break even in even lesser percentage of bed occupancy rate, but you might be compromising on the speed of your service, or you might be compromising on the quality of your service. Okay, then after the morning assessment, you have to prioritize discharge. So you should target 70% of the discharges that you have for the day, you do it by noon. Okay, so you have to expedite your lab, medication, reconciliation, everything. Then you have to see the transfer coordination. So the nursing transfer handoffs should have a clear timeline. So transfer as in, now I'm not talking about discharge, but in general for bed management. So say for example, a patient is transferred from ICU to ICU to ward, or ward to ICU, or emergency to ward, or ward to cabin. So those transfer coordination should be very smooth, and it should be done in 15 to 30 minutes of time. Okay, then proactively block the beds. So accordingly, whatever color codes you have for the status of beds, every staff, every nursing station, the operations people, they all should know that it should be updated on real-time basis. Okay, so that it is easier for everyone to check. It's easier especially for the front office people to check and tell the availability of beds in real time. Then real-time update, as I said, nursing updates, status in HIS after patient movement, cleaning, those things very important. Then escalation protocol. So whenever there are certain delays, whenever there are certain issues, it has to be escalated to the operations department, so that they intervene, they take help of maintenance or any other department and resolve the issues. Then you should have a evening review system where you analyze your occupancy, you analyze your turnaround times, you adjust for the next day's plan. Okay, so now we'll talk about the centralized HIS. So this is the dashboard which is important from the hospital operations point of view. So in your HIS, first thing, the real-time bed status should be there. We have just talked about that. With the capacity alerts more than 85%, that means your real time, as in the staff, they should be updating the bed status on real time, and the capacity alerts, if it goes beyond 85%, then there has to have certain alerts. Okay, then comes your patient flow tracking. So admission, discharge in 24 hours, how many admissions they are about to happen, how many discharges they are about to happen, your emergency department waiting times, average length of stay, your discharge forecast, all those things should be seen in the HIS system. Then your turnaround times, your lab, your radiology, it should be completely integrated to the centralized HIS. So you're able to track the turnaround time, whether it is the turnaround time for routine samples or whether it is for urgent samples. Separately, it should be visible. And pharmacy dispensing delays, if your pharmacy is integrated to the HIS, then you can also see the dispensing time. So dispensing time starts from the time when the patient gives the prescription and the time when the dispensing of the medicine happens. Okay, Then your bed occupancy rate. So current percentage versus your targets, 75 to 85%. As I said, the sweet spot. So you have to try to bring in your bed occupancy rate to 75 to 85% through your marketing efforts. Okay. So ethically, it is not. Ethically, it is bad that you try to get more patients somehow. But the point is, the patients who are there, they should be coming to the hospital because you are providing the services. So that is how you run the hospital. So current percentage versus targets, 75 to 85% sweet spot with ward-wise breakdown. So ward-wise breakdown as in, you may have different wards. You may have surgical medical ward, surgical medical ICU. You may have cabins, different cabins, number of cabins in different floors. So that way you have different nurse station. So nurse station and ward-wise breakdown of bed occupancy rate needs to be seen. Then staffing ratios. So as per NABH, every shift you see how many patients are there, how many nurses are there in every shift. So that way you at the end of the month you calculate your nurse patient ratio. So it is very important that your nurse patient ratio is as per the need. So through that you can take a call whether you still need nurse or the number of nurses that you have, they are able to manage the patient, manage the patient as per the bed occupancy rate. So tracking absenteeism of your staff, OT hours, so OT utilization, shift handover compliances. So whether the handover they are done correctly or not, those things needs to be seen in HIS. Then quality safety KPIs, your infection rate, falls, incident reporting, medication errors, between 30 days how many readmissions are there. So those things needs to be tracked in the centralized HIS. Then your revenue cycle. So your AR aging, your daily collections versus budgets, your insurance claims pendency, all those things needs to be seen and tracked in the HIS. So these things are very important to take managerial decisions. Alert system, so auto notification for critical threshold. So when there are bed crisis, as I said, 85%, when it is more than 85%. Your TAT breaches, so there may be certain times where your TAT is going beyond your defined TAT. Those alerts should be there. Equipment downtime, when there is a critical equipment down, there has to be certain alerts that this equipment had been down for more than the defined time. So those things needs to be tracked in HIS. Your equipment utilization, your CT, MRI, ventilator, occupancy, your maintenance schedule, your downtime, all these things needs to be tracked in the HIS. Your mobile accessibility. So whatever we have said here, if all those things are available in your hand through your mobile application, it is very good. Okay, so on the go you can see, you can discuss, you can whenever you sit in a meeting, you can always see your phone and check the stats and make your decisions accordingly. Okay, now emergency 24/7. So in the entrance to the way to the emergency, you should have a big signage, emergency 24/7 in red color. So you might have seen it in all hospitals that they have something like that. So process of emergency. So on the left side of the screen you can see when the patient arrives, you take out the patient and you shift the patient to a wheelchair or a stretcher as per the condition of the patient, and then you fasten the seat belt, fasten the belt. Then triage. So according to the patient condition of the patient, a patient is allocated to a certain bed, whether it is very critical, the red one, the yellow one, or the green one. Okay. Then initial assessment is taken, where it has to be taken by the doctor. It should happen within 5 minutes, tops 10 minutes. So immediately it should happen actually. So when the patient is allocated a bed in the emergency observation room, the doctor asks about certain history, everything, and then the condition, the symptoms, what pain they have, all that, and then an emergency initial assessment is done, and accordingly medicines are given, and then reassessment is done in order to see how the condition of the patient is changing. Okay, reassessment in emergency is another very important thing. One thing I'll just tell you, that an emergency should keep patients not longer than 3 to 4 hours. Okay, and once 3 to 4 hours, because you have to keep room for another emergency patient to come. Otherwise the emergency department can get very crowded. In certain hospital you have another holding place for patients, where patients are cannot be shifted in the IPD because the condition of the patient is not so severe, it's not so bad. The patient might need to extend it for a few hours more. So there's a holding space for the patient, and but generally patient should be either once a patient is so after initial assessment you try to stabilize the patient, and then you do reassessment, as I said. So after reassessment, it is either the patient has to be admitted in the hospital, so the patient goes to the inpatient department, or the patient goes out as per against the medical advice, or the patient gets well and the patient gets discharged from the emergency department. Okay. And another thing, for medico-legal cases. So in medico-legal cases, you need to identify that it's a medico-legal case, and you have to intimate the police. And if suppose the patient dies there right at the emergency, and their attendants say, please give us the death summary, death certificate. You cannot issue a death certificate if you are working in a private hospital. In India, it's generally death certificate is issued from a government hospital. The private hospital gives the death summary. Okay, so anything when it is a medico-legal case, police has to be informed. They have to be involved. Until and unless the police gives a written written document from their side that this person is, or this body is good to go, you cannot release. So to safeguard yourself, you have to document everything. So say for example, you don't know the cause of death, So you have to write in the death summary that cause of death is unknown because certain investigations could not be carried out. Okay, so you have to explain everything in the death summary so that you are safe from any legal problems in future. Okay. Now, biomedical engineering maintenance schedule. This is the aspect of the operations from the management point of view, what you need to see in biomedical engineering department. So first, they should have a very robust, complete and updated equipment master list, where they have all the details about whatever equipment is there in the hospital with proper code, when it was purchased, who are the supplier, the concerned person of the supplier, their phone number, where it is located, all details, the serial number of the equipment, everything should be there in the equipment master list. Then you should ask the biomedical engineering department to give a monthly report of what they are supposed to get, the list of equipment which will undergo AMC and calibration in the next 2 months. So say for example, the first week of April, you'll have to take April and May months schedule of calibration and AMC. Okay, and similarly you need to take the AMC and calibration which was done in the last month. Okay, so every month you have to take these 2 reports so that the biomedical engineering department, they do not miss out any calibration or AMCs. Critical equipment breakdown. So this is another very important aspect of the biomedical engineering department, where they have to monitor the downtime of critical equipments. And once you document the downtime of these critical equipments, you see that what kind of equipments are facing problem, and accordingly you take decisions of either replacing it or replacing certain spare part, or accordingly talking to the company so that this kind of problem does not happen. Because critical equipment means you will be compromising on the services of your hospital. Then so those things are there. So let's move on to the next. Now the pharmacy dispensing and inventory. So this side you can see on the left side of this screen, there's a whole flow chart given. So when you get the prescription, when a prescription is given in the pharmacy, you take a photo of that to do audit. Or if your audit system is very quick and robust, you can do it then and there. It may take 2 minutes of time, but when the line of patients are very long, it may delay your service time. So prescription given, then billing, and then the billing starts. So you check for the availability of the medicine, whether it is available or not. If it is not available, then you need to document it in your order book, or if it is emergency medicine and you see there is a stock out, then you write it in the emergency medicine stock out book separately. Okay, and then you tell the patient or whoever has come, attendant, that this medicine is not available. Another thing you can do is, if you have a generic alternative to that medicine, then you can call the doctor ask the doctor that can we give this medicine to the patient or not, the alternative one. And if the doctor agrees, then you can give it to the patient or attendant. So if your medicine is available, then you pack all the medicine. Then you double check if it is high risk or if it is LASA. You check the medicine, double check it, and then you explain it to the patient. So in case of OPD, you need to explain it to the patient. You should have a bag, envelope like thing where you put the medicine and you label everything there. So twice daily, thrice daily. So you can use 000, 0x0, 000 when it is morning, evening, night. Whether it is before or after food, you have to specify. And the time duration, for how long you have to give the medicine, you have to specify that in the same envelope. Okay, and then once you explain the medicine, how to take the medicines and all, and then you dispatch the medicine. Okay, so note and stock out, you prepare the bill, you pack your medicine. So when it is high risk or LASA, you check, double check, explain to the patient, I've said this is the medicine. So this is the whole process of medicine dispensing. And for inventory control, you can use a ABC analysis and FIFO. So I have covered this in pharmacy management, so you can check that video. And so this is the end of pharmacy. So thank you for watching this video till the end, and I hope you like this video. Please comment your views, please like this video, share this video, and follow this page for more such videos, and hit the bell icon so that you get notified. So see you again. Thank you so much.